Welcome back to the deep dive. Today we are sharpening our pencils and opening a book that strikes a bit of fear and awe into the hearts of surgical trainees everywhere.
Oh, yes.
We're cracking open the 28th edition of Baily and Love's Short Practice of Surgery, and we're going to zero in on Chapter 85.
Which covers the urethra and the penis. And I know the temptation is to think, okay, plumbing, just tubes and valves.
Right.
But if you treat this chapter as a simple anatomy list, you are going to miss the forest for the trees. This is really a survival guide for the emergency room.
That is exactly our mission today. We aren't here to just read the pages to you. You can do that yourself. Our goal is to interpret this, to act as a kind of ready reckoner for now. We want to pull out the visual anchors, the metaphors, and the don't you dare rules that really distinguish a competent doctor from a dangerous one.
We're going to cover the anatomy, sure, but we're doing it so you understand why a pelvic fracture turns the bladder into a hot air balloon, why a certain type of foreskin on a newborn is a do-not-touch zone, and why a certain type of gangrene requires you to, race the sunset.
So whether you're a medical student sweating over finals or a surgeon just refreshing your memory, consider this your audio revision aid. Let's start with the map.
Okay.
To understand the disasters, we have to understand the terrain. Baily and Love breaks the male urethra down into 4 zones. But help us visualize this. It's not just like a uniform copper pipe, is it?
Not at all. Think of the male urethra as a tunnel that travels through 4 completely different geological zones.
Oh, I like that.
The environment changes, and the lining of the tunnel changes with it. You start at the bladder neck, moving outward. First, you've got the prostatic urethra.
Which, as the name implies, runs directly through the center of the prostate gland.
Exactly. This is the widest part of the tunnel. It's lined with transitional epithelium, which is the same waterproof, stretchy wallpaper you find in the bladder.
Okay, built for storage.
Right. It's built to handle urine.
Right.
Then we hit a choke point, zone 2, the membranous urethra.
The gatekeeper.
The gatekeeper. It's the shortest section, maybe 2 centimeters tops. It passes through the perineal membrane and is surrounded by the external sphincter. This is crucial for continence, but here is the key takeaway. It is rigidly fixed.
It's anchored.
It's anchored to the pelvic bones.
That rigidity sounds like a vulnerability if the bones move.
A massive vulnerability. We'll get to that in trauma, but just remember that. Rigid fixation means it snaps easily.
So we push past the gatekeeper, and the tunnel widens again.
Into the bulbar urethra. This is the section housed in the perineum, surrounded by that spongy bulbospondiosis muscle. And finally, the penile urethra, which hangs free and exits at the meatus.
And you mentioned the wallpaper changes again here.
Yes. By the time you get to the penile urethra, the lining shifts from that stretchy transitional stuff to stratified squamous epithelium, basically skin.
And that matters because?
Because pathology follows the cell type. You won't see the same cancers or infections at the tip that you see near the bladder.
Okay, the map is established. Prostatic, membranous, bulbar, penile. Now, let's look at what happens when the construction goes wrong from day one. Congenital anomalies. The text highlights 2 major ones. Let's start with the one that acts like a silent killer. Posterior urethral valves, or PUV.
This is a diagnosis you cannot afford to miss. Imagine a mucosal flap in the prostatic urethra right near the start of our tunnel. It acts like a check valve.
A one-way street. A catheter can go in.
But urine can't get out. It's a total internal blockade.
And why is this so catastrophic?
It's the physics of back pressure. The fetus is producing urine, trying to push it out into the amniotic fluid.
Right.
The bladder pushes against this closed door, and the muscle gets incredibly thick hypertrophy trying to force it open, but it fails. The pressure then backs up into the ureters, they dilate, and eventually that pressure just hammers the kidneys.
So you end up with renal failure before the baby is even born.
Correct. It is a leading cause of end-stage renal disease in boys.
So how do we catch it? Baily and Love gives us a very specific visual anchor on the ultrasound.
The keyhole sign. If you look at the prenatal ultrasound, you see a massive, distended bladder that tapers down into a dilated prostatic urethra and then stops. The shape looks exactly like an old-fashioned skeleton keyhole.
Keyhole equals PUV. And the fix is plumbing 101.
Clear the blockage, endoscopic ablation. You go in with a camera and you just cut the flap.
Simple as that. Okay, let's move to the second anomaly. This one is much more common, about 1 in 300 births. You don't need an ultrasound, you just need your eyes. Hypospadias.
This is a classic exam topic. It's defined by 3 features. First, the ectopic meatus. The opening isn't at the tip, it's somewhere on the ventral side, the underside of the penis.
Feature 2.
Chord. The penis curves downward, looking like it's tethered.
And feature 3 is the one I want us to really focus on because it dictates the entire treatment plan.
The hood and foreskin. Because the urethra didn't form properly on the underside, the foreskin didn't close there either. So you have all this excess skin bunched up on top dorsally, looking like a hood.
While the underside is bare.
Exactly.
Okay, so here is a critical check-in moment for everyone listening. You are the doctor. You're examining a newborn. You see that dorsal hood. The parents look at you and say, "Doctor, we want to schedule the circumcision for next week." What is your immediate response?
You say no. You absolutely cancel the circumcision.
This isn't just an opinion, it's a surgical commandment. Why?
Because that hood is your spare parts bin.
The spare parts.
Yeah. When urologists go in to reconstruct the urethra and straighten the penis, they often need skin grafts to build the new tube. That excess dorsal foreskin is the perfect material.
If you circumcise that baby, you have thrown away the repair kit.
Precisely. You've complicated a future surgery immensely. So if you see the hood, put the clamp away.
All right, let's fast forward. We're leaving the nursery and entering the high-stakes world of the emergency department. Section 2. Trauma.
This is where that anatomy map we drew really gets tested.
Trauma is usually divided into 2 narratives. You have the crush, and you have the shear.
Let's create a fictional case study for the crush. Picture a 25-year-old mountain biker. He's hitting a trail, slips off the pedals, and lands hard on the crossbar.
The classic straddle injury.
He comes in, he can't pee, there is blood at the meatus, and when you examine him, there is a massive bruise on the perineum. But it's not just a random blob, it has a very specific shape.
The butterfly hematoma.
Why a butterfly? Why doesn't the blood just run down his legs?
This is a fascia lesson. The injury is to the bulbar urethra, that spongy section. The blood leaks out, but it's trapped by callus fascia.
Okay.
This fascia is anchored tightly to the fascia lata of the thighs and the posterior perineal membrane.
So the blood hits a wall at the leg.
It can't go into the thighs, and it can't go back toward the anus. The only place it can go is forward, filling the scrotum and the perineum, creating this distinct butterfly pattern. So, mountain bike plus butterfly bruise equals bulbar injury. Now, case study B, the shear, high-speed car crash, pelvic fracture.
This is a whole different beast. We are talking about the membranous urethra now, the gatekeeper. Remember how we said it was bolted to the pelvic bones?
Right, it was rigid.
In a severe fracture, the pelvis breaks and shifts, the bones displace. But the bladder and prostate are soft tissues. They want to float. The shearing force snaps the urethra right at the apex of the prostate.
So the pipe doesn't just crush, it tears completely apart.
Yes, and the bladder and prostate, now untethered, flows upwards into the abdomen. This gives you the classic X-ray finding mentioned in Chapter 85, the high-riding bladder.
Okay, so here's the scenario. You have this patient, shattered pelvis, hypotensive. You see blood at the urinary meatus. He has a full bladder and is begging for relief. The nurse hands you a standard Foley catheter.
This is the stop and think moment. The golden rule of urethral trauma, you do not touch that catheter.
Play devil's advocate for me? Why not just try gently?
Because you are operating blind in a minefield. The urethra might only be partially held together by a tiny, fragile thread of mucosa. If you shove a catheter in there blindly,
You'll just rip it.
you will almost certainly rip that remaining thread. You convert a partial pair into a complete transection.
Wow.
And now the bladder floats away, and a manageable repair becomes a major reconstruction.
No.
Plus, you're introducing bacteria into a sterile hematoma, inviting a pelvic abscess.
So rewind. If you are listening to this on your commute, say it out loud. Blood at the meatus equals NO blind catheter. So what do we do?
You need eyes on the inside. You perform a retrograde urethrogram, or RGU.
An RGU.
You gently inject contrast dye into the meatus and take an X-ray.
Yeah.
If you see dye leaking out, you know the plumbing is broken.
And to drain the bladder.
You bypass the damage, insert a suprapubic catheter. You go through the lower abdomen directly into the bladder. It's a safety valve.
Perfect. Let's move to section 3. Sometimes the pipe isn't broken or malformed, it's just clogged. Obstruction and strictures.
Strictures are basically scar tissue narrowing the tube. Historically, the big villain was gonorrhea. But today, we see trauma causing it. But the text specifically highlights a skin condition called lichen sclerosis,
Older texts might call this BXO or balanitis serotica
which
obliterans.
is a mouthful.
Yeah, let's stick to lichen sclerosis. What does it look like?
The visual anchor is white patches. The glands and the foreskin look like they've turned into whitish, scarred parchment paper. It's stiff. It causes fibrosis.
So the skin loses its stretch.
Completely. It causes severe phimosis, where the foreskin won't retract, and it can scar the meatus down to a pinhole.
And Baily and Love describes a specific pattern on uroflowmetry for strictures. When these patients pee into the machine, the graft makes a distinctive shape.
The box pattern.
Help us visualize the physics of the box.
Normally, if you or I pee, the flow rate graph looks like a bell curve. It starts slow, accelerates to a high peak, and then tapers off. But with a stricture, the pipe has a fixed, narrow diameter. The bladder pushes hard, but the flow hits a speed limit immediately.
It hits a ceiling.
Right. It goes up, hits that ceiling, and stays flat, a plateau, until the bladder is empty, then drops off. It looks like a square wave or a box.
That makes perfect sense. The stricture acts as a governor on the engine, and treating these often involves rebuilding the tube urethroplasty.
And the text mentions a specific donor site for the graft. It's buccal mucosa, the lining of the inside of your cheek.
From your cheek.
Yeah, it's tough. It's used to being wet, and it handles bacteria well. It's the gold standard for patch material.
Wow. Okay, now we've been very male-focused, but Section 4 does touch on the female urethra.
It does. It's much shorter, only about 4 centimeters, which explains why women are so much more prone to UTIs. Bacteria have a very short commute to the bladder.
And there's one specific pathology mentioned here, the urethral caruncle.
It's a benign vascular lesion, usually seen in postmenopausal women due to a drop in estrogen. The visual anchor here is a raspberry.
Raspberry.
It looks like a small, red raspberry-like mass popping out of the meatus at the 6 o'clock position. It's benign, but it can bleed. The key is not to mistake it for cancer.
Right. Let's shift gears to Section 5. Penile pathologies and emergencies. We have some scenarios here that sound incredibly painful. Let's start with phimosis versus paraphimosis.
A classic exam distinction, and mixing them up is dangerous. Phimosis is when the foreskin is too tight to retract. It's stuck forward. It's annoying, but it's rarely an immediate emergency.
Paraphimosis, on the other hand.
Paraphimosis is the emergency. This is when that tight foreskin has been forcibly retracted behind the glands and gets stuck there.
Why is that such an emergency?
Think of a rubber band wrapped tightly around your finger. The foreskin acts as a tourniquet. It cuts off venous return. Blood can get in, but it can't get out.
So the gland swells up.
The gland swells up, which makes the ring even tighter. It's a vicious cycle.
And if you don't fix it,
Arterial supply eventually gets cut off, and you get gangrene. The penis literally dies.
so how do you break the cycle?
You have to reduce it. You firmly squeeze the glands to push the edema fluid out, like squeezing a water balloon, and then pop the glands back through the ring. If that fails, you get a scalpel and you do a dorsal slit. You cut the tourniquet.
Next emergency. Penile fracture. Now, humans don't have a penile bone, so what exactly is fracturing?
The tunica albuginea. It's a thick, fibrous sheath that holds the blood inside the corpora cavernosa during an erection. It's incredibly strong, but if the erect penis is bent suddenly and forcefully, usually during vigorous intercourse, that sheath can snap.
And the text mentions a very specific auditory cue.
A loud crack or pop. It's audible. Followed instantly by detumescence, the erection is lost, and rapid swelling. We call it the eggplant deformity.
Is this a wait-and-see situation, ice and rest?
Absolutely not. This is a surgical emergency. You have to go in, find the tear, and stitch it up.
Moving from the broken erection to the erection that won't go away, priapism.
Right, an erection lasting more than 4 hours.
Yeah.
But you have to split this into 2 types immediately, ischemic
Yeah.
and non-ischemic.
Okay, how does the listener tell them apart in the ER?
Ischemic is low flow. Blood is trapped and can't get out.
Mhm.
It becomes deoxygenated, acidic. This is incredibly painful. The penis is rigid.
And if you stick a needle in it to aspirate?
You get black blood, dark hypoxic blood. This is the emergency because the tissue is suffocating.
Contrast that with non-ischemic.
Non-ischemic is high flow, usually from trauma. A small artery is ruptured into the tissue, the erection is painless, and it's not fully rigid.
And the blood test.
Bright red arterial blood. The tissue isn't dying, so you can often observe these.
Black blood equals emergency. Red blood equals observe. Now we arrive at the most terrifying condition in the entire chapter. Fournier's gangrene.
This is a true surgical nightmare. It is necrotizing fasciitis of the genitalia and perineum.
What are the warning signs? Because initially, it might just look like a bad infection.
The key is pain out of proportion to physical findings. The patient might have a small red spot, but they are screaming in pain.
Oh.
They look septic, and then you feel for crepitus.
That's the crackling sensation under the skin.
Yes, caused by gas-producing bacteria. And the smell. It's distinct.
The source material uses a very dramatic phrase for the treatment. Do not let the sun set on a Fournier's.
That means you cut immediately. You don't wait for the MRI. You take the patient to the OR and you debride. You cut away everything until you see healthy, bleeding tissue. If you hesitate, the mortality rate skyrockets.
From the nightmare of gangrene to the alphabet soup of infections, Section 6, STIs.
Yeah, Baily and Love gives you the classic run-through, urethritis. If you see gram-negative diplococci under the microscope, it's gonorrhea. If not, it's usually chlamydia.
There's a specific syndrome mentioned, Reiter's disease. It has a catchy mnemonic involving a tree.
Can't see, can't pee, can't climb a tree. Conjunctivitis, urethritis, and arthritis, an autoimmune reaction.
And regarding ulcers, this is a common spot for confusion.
Key is pain. Herpes gives you painful vesicles. Chancroid gives you a painful ulcer. But syphilis gives you a chancre, which is a painless ulcer.
So if it doesn't hurt, you should be more worried.
In a way, yes. Finally, let's touch on carcinoma of the penis.
Okay.
Fortunately rare in developed countries, but devastating. Almost always a squamous cell carcinoma.
What drives it?
Chronic inflammation, and HPV, specifically types 16 and 18. Risk factors are smoking and conditions like phimosis or lichen sclerosis that trap smegma.
The book mentions a strong protective factor here, which brings us full circle.
Neonatal circumcision. The text is clear that it effectively eliminates the risk of penile cancer.
This is a complex area. The text presents the surgical fact, but globally, we know this is a debated topic.
It is. It's a fascinating tension between pathology and preservation. Baily and Love presents the clinical data, but the decision-making in the real world sits in that gray area.
And clinically, how does this cancer usually present?
It hides. It often starts as a painless ulcer on the glands. But because many of these men have phimosis, they can't retract the skin to see it.
So if you have an elderly patient with a tight foreskin and you feel a hard lump underneath,
You have to be suspicious. Never ignore a lump you can't see.
we've covered a massive amount of ground. From the keyhole sign of PUV to the butterfly hematoma of trauma.
From the hooded foreskin of hypospadias to the box pattern of strictures.
So let's distill this. If the listener is walking into the ER tomorrow, what are the big 3 life-saving rules from Chapter 85?
Rule number 1. In pelvic trauma, blood at the meatus means stop. No blind catheter. Do the RGU.
Save the urethra.
Rule number 2. In a newborn, a hooded foreskin means hypospadias. Put the clamp away.
Save the skin.
And rule number 3. Fournier's gangrene waits for no one. Pain out of proportion plus crepitus equals immediate surgery.
Save the life.
Exactly. Clear, concise, and clinical. Now here is a final thought to chew on. We talked about how the urethra changes its lining halfway through.
Yeah.
It strikes me that the penis is one of the few organs that sits strictly on the boundary between the internal sterile world and the external dirty world. It is. It's a portal, and that's why the pathology is so varied. It gets hit by internal pressure like PUV, external trauma, internal bacteria like UTIs, and external viruses like HPV. It's a high-traffic intersection for disease.
Something to think about. And here is my call to action for you. If you have the book, open Chapter 85, look at the X-ray of the high writing bladder, look at the diagram of the box pattern flow rate, cement those images in your brain.
Visualization is everything in surgery. If you can see the anatomy in your mind's eye, your hands will know what to do.
That's it for this deep dive into the plumbing and pathology of the male anatomy. Thanks for listening, and we'll catch you on the next round.
Stay curious.